Welcome to Alzheimer's Demystified. I'm Phil Gallagher. Thank you for joining us. One of the advantages of advancing technology these days is advances in medicine, which has increased our mortality. Unfortunately, that brings along a set of challenges, one of which, of course, is Alzheimer's disease as we age. Here with me today to discuss the clinical, pathological, and human aspects of the disease are Dr. Peter Moran. Thank you, Doctor. Dr. Moran is a neurologist at the Department of Veterans Affairs over here in Bedford. Also, Dr. Omanan Kool, who is a doctor of biochemistry and clinical pharmacology at the University of Massachusetts Worcester, and I know I got that wrong. It's at the Graduate School of Nursing in Worcester, and it's pharmacology and biochemistry. Okay, and our own Brenda Pappas, who is a licensed social worker here for the Burlington Council on Aging. So let's begin. This is naturally a disease that concerns all of us now as we're advancing in age. Of course, you're not, Brenda. We are. Doctor, why don't you start off with us and give us an idea of the disease itself, some of the history of it, how it's advanced in terms of our knowledge of it.
So first, dementia refers to the progressive deterioration of memory and other cognitive functions to the point where people have trouble performing their intended activities. And many things cause dementia. Alzheimer's happens to be the most common cause of dementia.
So this isn't the one thing that all advancing people can experience as far as cognitive deterioration.
Correct. In fact, the number of causes of dementia are too numerous to count. And it's important for people who experience cognitive impairment of any type to consult with their doctor and potentially a specialist to rule out other types of processes that can be affecting their thinking.
Tell us who Dr. Alzheimer's is and when did this come about? I mean, I presume as we advanced into the 18th, 19th century, instead of living to 35 or 36 years old, suddenly we were advancing in our mortality rates.
Well, it's interesting. Dr. Aloysius Alzheimer was an Austrian-born German psychiatrist at the turn of the last century, who in 1907 published the first report of a young woman around age 50 who suffered dementia. And it was notable when he looked under the microscope, he saw the same things that we see under the microscope today, namely plaques and tangles. And it's interesting that when he first published the paper, it didn't really get that much attention. And it was a few years later that the condition was named after him.
In those days, it was twilight, senility, any type of description. Grandpa's just losing it, that type of thing.
Right. It was considered a progressive cognitive deterioration, much as it is now. In fact, the case that Dr. Alzheimer examined was a 51-year-old woman. It was considered to be a rare disease. Now that we're living longer, as you mentioned, we recognize that it's not so rare. Some studies suggest that up to 50% of people in their 80s will exhibit some type of dementia, most commonly Alzheimer's.
And how is this different from a pathological standpoint? How is dementia different from Alzheimer's, and what are the components? What is plaque? What is tangles? What are those definitions?
Well, what we have already heard that Dr. Alzheimer actually noted the two major pathological findings, the plaques and the tangles. But that's what we call them now. He just saw deposits and found out that was probably the case, led to the dementia of the woman. But lately what people have done using a lot of research over the last 50 years now, people have identified the processes that lead to the formation of those deposits. And one of the items we talk about most of the time are what we call the amyloid plaques. And amyloid plaques essentially are sticky deposits that happen to occur in the brain, and they don't come from outside. They are this is a protein within the brain in the cell, on the cell membrane, which falls apart, and once it breaks down, portions of it become sticky, and once the stickiness starts, those sticky deposits deposit themselves outside the cells, and those are the ones which you notice as the plaques. And the second piece is what we call the neurofibrillary tangles. Now, they are part of those tangles. There's a normal system of what we talk about as essentially you could think of it as a railroad track within neurons, and that railroad track is important in transporting material from the one end of the cell to the other end of the cell within the neuron, which is important. But what happens is, in some individuals, this railroad track begins to fall apart. And once the railroad track begins to fall apart, those proteins break down, and then they accumulate in the cell, those portions that have broken up. And because these broken pieces accumulate, and they accumulate as what we talk about as tangles. And those tangles are toxic to the neurons. That much we know. Now, those are the things even Alzheimer saw, those tangles, and what we call now the tangles, and he saw the plaques. And that pathology has not changed. But what is also interesting is that not every patient who has Alzheimer's disease will have plaques and tangles. What is interesting also, that there is a recent study which just came out actually in Journal of American Medical Association, JAMA, May 15, where they studied a lot of patients using what we talk about as the positron emission tomography, where you can locate these tangles, where you can locate these amyloid plaques. What they found out is when we look at normal people, 50% by about age 50, about 10% of people who are normal cognitive function, they have plaques. And by the time there are people who are in their 90s, about 44% of those people, although they are normal, they have plaques. But in contrast, patients who have mild cognitive problems, about 27% by age 50, they have these plaques. While as by the time they reach 90, 71% have these plaques. But the question then, also the problem, as I pointed out, is that, as I said earlier, that 12% of the patients in their setup who had Alzheimer's disease did not have any amyloid plaques. But at the same time, there were people who had amyloid plaques, but they had no dementia. So that tells you that having or not having amyloid plaques necessarily is not a direct correlation, but although you see them in patients.
So since I bungled the opening, let's go back and say Associate Professor, Department of Molecular Biochemistry and Pharmacology at UMass Worcester. Okay. Now, how about the synapse? You talked about the neuron and the tangles and the railroad tracks.
Yes.
What is the synapse, and what portion of the brain are we talking about that's affected directly by this?
So that's another interesting point, is that in the brain, if you look at the brain in general, there are regions of the brain that are involved with memory. There are regions of the brain that are involved with our motor functions. There are regions of the brain that are involved with our sensory functions. Now, in the Alzheimer's disease, the first region that is noticed to kind of get affected is what we call as the hippocampus. And associated with that is another piece which is called entorhinal cortex. Now, those two areas are involved, the hippocampus particularly is involved with memory. So you see.
And where is that? Point to that in the.
Well, that is that is well, it's in the brain. It's difficult to point out. In fact, maybe you want to say something. Where exactly can I say that? I have a slide where it shows where the hippocampus is.
Okay,
and
well, we'll put that up here.
So, what is interesting is that there is there is an association between the hippocampus, entorhinal cortex, and the olfactory bulb in the brain. Olfactory bulb is involved with our sense of smell. Now you see that because the olfactory bulb is connected to our nose, that people have theorized that maybe Alzheimer's disease, because it affects the hippocampus first, maybe the reason is that there are infections that get into the brain and affect the hippocampus. We don't have exact details because people have not really done a lot of work with that, but there are indications that that might be also the case. So that might be a reason that hippocampus gets injured. But why does it happen, the case in only some people, not in everybody? That's another piece where genetics is involved and a whole bunch of other factors.
Peter?
So another possible connection between the olfactory system and the hippocampus is that they are both part of what we call the limbic system.
Yes.
And this is a system in the brain, in the human brain, that functions in emotion and memory. And it is a phylogenetically ancient part of the brain that evolved very early in the evolution of our brain. These brain regions have particular cellular organization, and why they may be more susceptible to Alzheimer's disease could have something to do with their wiring, or it could be due to an infection through the olfactory system.
Brenda, let's talk about the human aspect of it here. You have quite a clientele up at the Council on Aging. You're in the elderly community on a daily basis. When we were growing up, cancer was the #1 thing. Everybody had a great fear of this. In the old days, was a death sentence essentially. How has that changed now in terms of the fear of the elderly population? Is this now replaced cognitive degeneration? Is this now replaced those items as the primary concern of your clientele?
I think it's true. A lot of people do worry very much about becoming impaired with Alzheimer's. They worry about their memory and pay attention to that. So that's a good thing that people are paying attention. We do have a lot of folks here in Burlington and surrounding areas, of course, that are struggling with this disease, and families that really need assistance. So I think there's obviously a lot more, people know a lot more about Alzheimer's now. They know more about how to get help, and that's one of our jobs at the Council on Aging, to help people get connected with information and services. So yes, I would say it's pretty dreaded. It's a
Now, in
dreaded
your
disease.
outreach, are you screening? Are you discussing with the various clients what they should be looking out for in terms of
Well, I think
their own concerns?
typically people will come to us when they've already noticed a problem, usually a family member, or sometimes people come on their own, but generally it's a family member who's reaching out looking for help. They've noticed changes in their parent or their spouse or their friend or their neighbor, and they're concerned.
Loss of keys, things of that sort.
That kind of thing, or maybe people aren't really taking care of themselves very well anymore. That's very typical. Having trouble keeping up with their mail, having trouble keeping up with just day-to-day activities that formerly were no problem. A lot of safety issues come up. Driving is a big one. So generally, we hear from family members when they start to notice that their parent or their loved one is really not functioning the same way they always have.
How about in terms of ability from a cognitive testing standpoint to determine whether or not somebody has got the disease?
Well, as Brenda said, by far the most common first symptom is impairment of short-term memory, not being able to remember what happened a few minutes ago, then a few hours ago, then a few days ago, and that's the way it goes. It progresses in that fashion until people don't remember what happened for the past 30 years. So most of our assessments focus on impairment of memory. In fact, dementia affects all cognitive domains eventually, and in some people it actually starts in other parts of the brain than the hippocampus, so that the initial symptoms might be judgment, and people may become irritable or behave inappropriately. The first symptoms can be complex visual processing symptoms where they don't recognize the relationship between objects and their environment. There are different variants, but by far the most common is the short-term memory impairment, possibly followed closely by a disturbance of mood. Many people will develop a first ever depression, and that's now recognized as a likely early sign of impending Alzheimer's disease or dementia. The assessments focus first on defining the pattern of cognitive impairment. And this is often done either in a brief neurological assessment in a doctor's office, or if necessary, in a much more extensive evaluation performed by a neuropsychologist. And these assessments will evaluate performance in memory, in language, in executive function, and visual spatial functions, and a host of other separable and testable cognitive functions, and determine whether A, there is any performance that is below expectation, and B, over time, if there's any progressive deterioration of those
So you
functions.
begin by establishing a benchmark?
Right. So in somebody who we're not sure about, because they're perceiving that there's a subjective problem with their memory or some other cognitive function, we will certainly obtain a baseline and then follow them over time. And that remains our most sensitive test for detecting dementia, is the neuropsych testing.
So at this point, there is no blood test, there is no brain scan that can determine definitively whether or not somebody has contracted this disease?
Well, at this time, there is no biomarker. People have tried the smell test, for example, that has, because of the connection I just mentioned. People have tried doing the PET scans and correlate the plaques or the amount of plaque. Although you can correlate that, but still that does not necessarily mean the person has dementia, as I pointed out earlier, or Alzheimer's disease. Now, what is also interesting is that as I pointed out earlier too, not everybody with plaques will necessarily have Alzheimer's disease. What is also important to point out that a person who has dementia, clinically people have to ascertain, is it a reversible dementia or is it really Alzheimer's disease? Because you can have somebody with dementia which may be reversible, which maybe the person has hormone issues, maybe have vascular issues, or maybe have vitamin issues. So those are electrolyte issues, but they could show the same manifestations which look like dementia, which are like dementia. Right. So those are reversible, but the patient with Alzheimer's disease will have markedly progressive symptoms, and those can be continued, those can be established once you have a benchmark and you keep going. But at the same time, you have one more point, is that we do have the PET scan technology now where you can locate the plaques, but that necessarily does not mean the person has Alzheimer's.
Right. Do you see that in your practice, that there are other examples of
Well, yes, and I think that's why it's so important for families to investigate, for, not to just assume, well, my mother's 78 now, so I'm not too surprised. She has these symptoms. It could be something that could be helped, and you wouldn't necessarily assume that it is Alzheimer's, but really should be investigated with a complete neuropsych evaluation. We always push that because it helps for so many reasons. It can help the family plan. It gives a real, better picture of what to expect. You want to be sure there isn't something that could be treated that's not being treated. It can impact on financial and legal matters that need to be put in place. So there's really a lot of reasons to have a thorough evaluation, not just assume that someone's getting old and they're forgetting.
The natural progression should be loss of memory, but not necessarily. We know a lot of 90-year-olds as sharp as a tack.
Yeah, and in that early stage of evaluation when it's not really clear, there is no definitive diagnostic biomarker. So the best we can do is diagnose probable Alzheimer's disease, but we further resolve probable Alzheimer's disease into probable with or without biomarkers, because there are several biomarkers that correlate closely to the tune of 90+% with Alzheimer's disease. And those include chemical tests that we do on the spinal fluid from a spinal tap, PET scans, both standard PET scans and also the new amyvid scan that detects the amyloid. And I'm sure that soon we'll have another one with the tau protein for the tangles. There are a number of biomarkers that can be used, and they will increase the probability of the accuracy of the diagnosis. So the different stages of accuracy are probable Alzheimer's and probable Alzheimer's with biomarkers.
Are incidences increasing in the way we seem to perceive that it's increasing?
Actually, the recent data suggests the opposite. There are reports from around the world that the incidence might be decreasing. Why, nobody knows. Maybe we're all living healthier, but it's not clear.
Well, could it be diet? Is it drugs and alcohol? Is it environment? Is it what do you think are the major contributors that you see in terms of the incidence of the disease?
I mean, that's what Peter pointed out, that maybe people are living healthier. Although we live longer, but people have become more aware of their diet, more aware of exercise. That's why there was a recent, what we call the finger study. I think that's called a finger study that was done in Europe, and that they showed, yes, altered lifestyle, meaning exercise, meaning diet, does help in kind of thwarting those insults which progress a person into loss of memory over time. And over time, what we take for granted is that as we get older, our brains will shrink to a certain degree. We will progressively lose some memory, but not necessarily get Alzheimer's disease.
Peter?
So I would say that one of the major revelations over the past 10+ years in Alzheimer's research is the recognition that risk factors for vascular disease and Alzheimer's disease completely overlap. So high cholesterol, diabetes, high blood pressure, smoking, drinking, sleep deprivation, migraine, all the things that are stroke risk factors, vascular risk factors, also increase risk for Alzheimer's disease. Why is that? It's not entirely clear. Many people in the research community regard Alzheimer's as an end-stage vascular response, and more data from clinical research tells us that people who take care of their blood vessels by exercising and living a healthy lifestyle have a lower risk of cognitive decline. So take care of your blood vessels.
How has outreach
Exercise.
changed over the last 25 or 30 years? I mean, 30 years ago we didn't have a council on aging. Now everybody's got one. Everybody's addressing the issue of aging. How is outreach affected by this? You encouraging diet changes, encouraging?
Well, absolutely. The senior centers now are very active places. Exercise is extremely popular. You mentioned exercise. We have 5 days a week, some sort of exercise going on. They're very popular. The social engagement piece is also really popular. So we try to keep people as engaged as we possibly can with all kinds of activities. How has outreach changed? I think that people expect more from their senior center now. They're looking for different types of things than they used to. There's Zumba now, there's yoga now. So we have more seniors now, I think, in our community. I think there's a very large number. I'm trying to remember what the exact number is, but it's large. So
Like 3,500, somewhere in that order, right? If memory correct.
I think it's even more than that, over 60. But so we're very busy trying to meet the needs of all our seniors.
Including education. I understand you have a number of educational programs there.
We have a lot of educational programs. A lot of them are history related, but more health related. Again, we try to educate people about heart disease. We try to educate them about eating right. We try to educate them about stroke warning signs and all of that, because that's what people a lot of people want to know that, which is a really good sign. Also,
And
people
those
want
that
to
don't,
be.
you want to tell them they need
Well,
to know about it.
It's good that people realize that they want to stay healthy, and so they get a lot of good information at the senior center.
How about the critical thinking skills, the cognitive gym, if you will? Do you see any advances in that area? Does this, do you think, contribute to such things as lumosity or crossword puzzles or trivia or any of the things, bridge, any of those things really contribute to the possibility of warding off dementia or Alzheimer's?
Go ahead, I will say something later.
Insofar as Alzheimer's disease is a intrinsic amyloidosis, it seems very unlikely that exercises will prevent it. That doesn't mean that using your brain for various activities can't help you maintain a certain level of functioning. And people who do lots of crossword puzzles tend to get much better at crossword puzzles. I usually recommend that people socialize, because when you're socializing, you're using your memory, your judgment, your language, and just about
Emotion.
every other cognitive function that you possess. And so the more you use the organ, the better it seems to function, just like a muscle. The more you use it, the better it does.
So you can come and play Scrabble. That's the reason for coming to the senior center, but it's really the social part that's important. As Peter said, it's the interaction with other people.
I mean, that's what is interesting, that over the last 30, 40 years, people have concentrated on amyloid or the tau as so-called pathology, and which we know is. But at the same time, it has also revolutionized the thinking about what really causes Alzheimer's disease. We don't know exactly, but that's the hypothesis which is being developed and which is being pushed forward, is that Alzheimer's probably is part of the inflammation protective piece that happens in brain because the brain wants to protect itself from some injury. So somehow some injury has happened in the brain, maybe because of an infection, maybe because of vascular problems, or maybe something else. We don't know. And because of that injury, brain reacts and leads to inflammatory response. And that inflammatory response, although it is protective, also leads to long-term alterations of the cells in the brain. And those changes cannot be reversed. Now, because it's a progressive problem, because it's a long-term problem, what happens is people start getting those alterations maybe 30 years, 40 years before they really show the clinical symptomatology. Now, that tells you that what we need to do is we need to have a lifestyle way back from childhood to keep thinking about how to protect our brain. And we don't have that at the moment, because we don't have the hypotheses in place to have a plan, a program for everybody from the beginning. How do you protect your brain? And that's why, because it's a long-term process, that's what Peter pointed out, although you might do crossword puzzles, but that is not going to prevent. But what that is going to hopefully do is allow you to socialize, allow you to interact with more people, allow you to use all the faculties in the brain, and maybe get more social support, which is important and in an elderly person to begin with. So that's the problem there.
Well, what about drugs and alcohol and the difference between ataxia, for instance? Is ataxia a form of dementia, or is that a form of brain damage?
So ataxia technically refers to problems with coordination, and it can be
Balance.
it can be a limb ataxia, it can be a gait ataxia where people can't walk straight, as if you're inebriated. So the short answer to your question is no. But as people reach the very advanced stages of Alzheimer's or any other neurodegenerative condition, they may develop ataxia.
Let me give you a specific question as it relates to your practice at the VA. Is there any indication, for instance, that PTSD and trauma and battle, those things have any difference in the population in terms of leading to cognitive diseases?
Well, the VA is most certainly leading the way in studying the relationship between PTSD and dementia. It's a little bit murky right now. The picture is a bit murky. The VA is following a very large cohort of veterans who have unmistakable PTSD, and we'll see how they do. Certainly in our Alzheimer's unit, we have had a number of World War II veterans who spent time in concentration camps, had PTSD squared. So I think most of us in the field suspect that there is a relationship, and that PTSD may stress or injure the hippocampus in a way that makes it vulnerable to subsequent Alzheimer's type pathology. But it's still a bit too soon to say with certainty that they're connected. And as far as drug use goes, I think you mentioned drug use as well. It's also unclear. Certainly there are drugs of recreational drugs that affect memory, like marijuana. There was recently a large study looking at opiate use, showing no connection between opiate use and dementia.
Oh, because it kills you before you get old enough
Maybe
to get
that's
it, right?
maybe that's it. It's right now it's clear as mud. I think there's an awful lot of work to do in that area. I suspect that we will find connections between both PTSD and drug use and subsequent dementia.
What is also interesting in this is that there is a certain gene called the apoprotein E, and some of us have a certain type of apoprotein E gene, and some other people have another variant. Now, the people with the apoprotein E variant 4 are more susceptible to developing amyloid and getting Alzheimer's disease, whereas other variants are not. So that's why it becomes much more complicated to really predict who is going to get Alzheimer's and who is not. Although they may have gone through the drug use, they may have gone through alcohol use, or they may have PTSD, or they may even have Parkinson's. So it's kind of not sorted out that way.
In your clientele, and I'll ask you the clinical questions about early onset and later onset Alzheimer's. But what is your typical age group? Do you have some early onset clients, or is this more infrequent?
We do have younger onset folks that we work with. I would say majority of people are older, but yes, we also try to meet the needs of younger people who are diagnosed, which are different, quite different than people in their 70s, 80s, and 90s.
Right. Quite a different set of challenges.
They have a different set of challenges. They're in a different place in their life when they're diagnosed. They're financially usually not at the same place that older people are.
Familial obligations.
They may have, they may have still children at home. They may actually be working or have just had to leave work. So it's very different.
Well, tell us the difference between the two of them. I mean, it has the same pathology, I guess, is the
It does.
proper question.
So the single most significant risk factor for Alzheimer's disease is age. So it's something like 15% in your late 60s, 30% in your late 70s, and 50% in your late 80s.
Well, clinically,
That's
you don't
okay.
see any difference, though, between the amyloids and all of the same symptoms.
brains look
It's
the
just the
same.
difference.
Right. In all cases, under the microscope, it looks the same. We see amyloid plaques. We see neurofibrillary tangles. We refer to early onset Alzheimer's disease if it occurs before the age of 65. But that does not mean that it's necessarily autosomal dominant genetic Alzheimer's disease. So most cases, over 95%, are sporadic, and people who have late onset sporadic Alzheimer's disease do not have the specific mutations in the 3 genes that we know of that can cause Alzheimer's disease to start early. When it does start early due to a genetic mutation, it can start in the teenage years. There's a big family in Colombia that's being studied right now in a prevention study where it frequently starts in the 3rd or 4th decades. At least it becomes symptomatic then. It may actually start long before then. But those genetic cases are a distinct minority, well under 5%. Many people who develop Alzheimer's in their 60s wonder if they don't harbor the mutation, and they come into clinic asking if they should be tested. And sometimes we test them. We can in 2016, we can sequence the gene and and see if they have any of the mutations.
Is there a typical decline in terms of time from the time, say, you contracted or you've been diagnosed to the time where you become an full-blown Alzheimer's patient?
So we don't know, in general, exactly when it starts. All right? We know that when it becomes symptomatic, if we look under the microscope or use a PET scan, in most cases we see lots of amyloid. But we don't know how long it's been accumulating. We assume that the accumulation has occurred over the course of decades. But we don't really know that for sure.
Takes a long time to.
There's data coming out on this point, but it's not 100% clear right now.
How about prevention of the accumulation?
One thing is there that what Peter talked about, the Colombian study, which is a major study going on about the early onset, which is localized there. But again, that is a genetic mutation they have. Now that study is we are hoping that study is going to bring up more avenues to treat the regular Alzheimer's disease, or to detect the regular Alzheimer's disease, what we call the late onset. Now, what is also interesting about that is that pathologically you see the same things in both, whether it is a Colombian study or here. But what the Colombian study we are hoping is going to do is provide us some tools which will be useful. But the Colombian study also raises ethical questions about when you have people getting Alzheimer's disease in their teenage years, or you can test them for the gene. Do you tell them that they will get Alzheimer's disease later on, or do you leave it alone? Because one of the study authors actually was talking about how he was talking to people there, younger people, and they were saying, well, I don't want to get tested because it is essentially you're telling me you are going to die.
Death sentence, sure.
It's a death sentence.
Right.
So that raises those questions. But it's good that in the sense that we have only very small number of people, very small percentage of population who gets the early onset disease.
Okay, we've only got about 20 minutes left, so I want to go into 3 areas. We want to talk about research, treatment, and then I want to close with Brenda and talk about the family challenges to the individual, outreach, costs, services, etc. So let's start with research. What's going on right now in terms of a major way in addressing this issue?
So the major research going on right now continues to focus on the amyloid hypothesis, which Omanan described. And this hypothesis is that the amyloid that we see under the microscope and on the PET scans is the cause of the dementia. So there are many, many clinical trials going on right now to block the production of the amyloid, to break up the amyloid, to clear the amyloid out of the brain through both, well, mostly passive immunization at this point. And we'll see. It's a very interesting phenomenon because I think, as you mentioned, Alzheimer's does not occur in any other species that we know of. Mm-hmm. It's a uniquely human disease, and we cannot be certain that the amyloid is the cause of the dementia until we do the definitive experiment in human beings where we remove the amyloid
and see if
the dementia goes away. Right. So over the past 10 years or so, we've seen 7 or 8 clinical trials that have reduced the amyloid a little bit without any clinical effect. So this new Colombian study is focused on the very early stage, and that's why the study is being done in this family in Colombia, because we know when they're going to get it, so we can try to prevent it.
What's happening in the laboratory?
But at the same time, the current thinking is that although amyloid, you see the amyloid in pathology, but biologically, is that the reason? We don't know, but that's why people have advanced the newer hypotheses about inflammation, that essentially you have an injury to the brain because of various reasons, and then because of that you have the inflammatory response, and it's a protective thing, but at the same time the protective thing goes a little awry, changes the brain cells in a way, and that cannot be reversed. Now the question then, what people are trying to ask and answer is that if it is an inflammatory disorder, if it is an inflammation happening in the brain, can you reverse that inflammation by providing drugs that reduce inflammation? And people are advocating using anti-inflammatory drugs for long term. And that's why one of the things people have advocated is, for example, using the Indian spice turmeric, which is an anti-inflammatory over the lifetime. So if you could use that, will you reduce the inflammatory response and maybe reduce Alzheimer's?
Is there less of an instance of Alzheimer's in the Indian population?
Well, they have done some studies to show that yes, it is true, but I don't know a lot of replication has not been done. Still, the data is being, there were some bunch of data earlier, but still people are revisiting it to see if anti-inflammatories are really protective. That is the hypothesis, and that is where people are trying to modify what we call the so-called the amyloid hypothesis. There are advocates for amyloid. There are advocates to dump amyloid hypothesis. There are people like Rudy Tanzi here in Boston. We have Selco. We have Carl Harrop. He's in Hong Kong. They all kind of, by and large, are trying to modify this hypothesis that has been used over time, over the last 30, 40 years. And we have not gotten really any tangible medications out of that hypothesis.
So we've made no progress essentially in treatment options? When somebody comes into you, you've gone through the clinical examinations and you've done the baseline, et cetera. What then, when you've determined that's the diagnosis, what is the regimen you propose?
So if a diagnosis of probable dementia or probable Alzheimer's disease is made, there are a number of things to think about first. And the first and foremost consideration is safety. So people can be injured by machines like cars and stoves, medications that are often dangerous if they're not taken properly because you forgot whether you took it or not, and crooks. There are a lot of scam artists out there who prey on people who have cognitive impairment. So those safety factors, machines, medications, and crooks, are the first thought. Secondly, living a healthy lifestyle for all the reasons that Armanan mentioned, to protect your blood vessels and protect your brain is an important thing to think about right up front. And then socializing as a way to use your brain, to exercise it in the best possible ways. Once those things are considered and are in place, everyone should consider the 4 medications that have been approved by the FDA for treating Alzheimer's and dementia. They fall into 2 classes, chemically speaking. So there really are 2 classes of medications, and the current standard of care is to use 1 member from each class. We refer to this as combination therapy. And the reality is that these medications work. They improve cognition and they slow progression, but they're only weakly effective. So in any one individual, it's often very difficult to say whether or not taking the medications has been beneficial. On the other hand, if you look at large studies or the population as a whole, you can see definite effects. So if our goal is to help Mr. Jones to think better, well, the medicines might or might not be helpful. But if our goal is to keep 1 million people out of nursing homes, then the medications are definitely helpful. So those medications that we have approved right now to treat cognitive impairment and Alzheimer's disease, they don't work so well. They work a little bit, but they don't work so well. What we're better at is treating the more difficult psychiatric symptoms that evolve in the later stages of Alzheimer's disease. The anxiety, the agitation, the psychosis, the OCD behaviors. We have a very deep toolkit for helping people go through the more advanced stages of dementia without suffering terribly from these other
Can
types of
violence be
psychiatric symptoms.
a manifestation of it as well?
It frequently is. I'm not sure of the exact numbers, but something like 50% of people who go through the more advanced stages of Alzheimer's disease will experience some degree of impulse control and agitation problems that require medications for their comfort and the safety of the people around them.
So the diagnosis comes in, it now essentially comes into your domain as far as outreach and services are concerned. How do you spring into action from day one?
Again, so if someone's already been diagnosed, and first want to make sure they have been to the doctor, and if they've noticing these changes, that they've done something about it in terms of trying to investigate. But part of our job as outreach is to help people understand what's available in the community that can help. The Alzheimer's Association is very helpful. They have a 24-hour hotline. They have support groups. I run one at the Burlington Council on Aging. There's over 100, I think, in Massachusetts. And
These are for both the client and the family members?
Well, some support groups are for people with dementia, and many are for the caregiver. So the Alzheimer's Association does have some support groups, and you can look online at the website for people with dementia, but most of them, I would say, are geared more toward the caregiver. So we want people to know about support groups. We want them to know about home care services. We want them to know about day programs, which can be really helpful. We want them to know more about what types of facilities can be a more supportive setting once someone may not be able to stay in the home any longer. If the family can't manage the care any longer, sometimes they reach that point, sometimes not. But if they do, assisted living facilities with memory care units can be helpful. Long-term care facilities can be helpful.
Okay.
For veterans out there, they should be aware that the VA has tremendous resources for people with Alzheimer's. From the earliest stages of diagnosis and the latest and greatest diagnostic scans, right through to the final stages. The VA really takes care of the veterans who have dementia.
Now, the stress ultimately is lodged in the caregiver eventually. How are you able to support them in terms of providing additional services?
Well, we tell people, you really can't do Alzheimer's alone. You really do need to have a support network. So we try, again, with the support group we have at the Senior Center, helping people build up their own personal support network, make sure they're taking advantage of any benefits they might be eligible for services, subsidized services, private pay services.
And you have a roster of all of these things that are available?
Yes, so we're able to help people get connected in that way. The other thing about the support groups are people, not only do they have a chance to just vent and feel like they can talk about any of their struggles in a safe place. In addition to that, they learn from each other too, and they really support each other quite a bit, and so they're useful, the support groups, and they're all over the state.
They're very useful. Yeah.
Now, what are you finding for longer extended care? I know that there's been a tremendous increase in the number of facilities, but is it matching the need? Assisted living and Alzheimer's units. Are you able to find beds, for instance?
I think so. I mean, I think that more people are going into assisted living type settings than ever before, only because I think there's more of them. There's more seniors, there's more assisted living type facilities. I think a lot of people do stay in their home setting for quite a long time as well, and that's very possible now. There's probably more available now than there was years ago in terms of services.
In-home services?
In-home services, right. Yes.
Visiting nurses, things of that sort?
Yes, visiting nurse. In our area, it's Minuteman Senior Services that provide subsidized services.
Including meals, for instance?
Meals on Wheels, right. Help with personal care, help with companionship, supervision, help with laundry, help with grocery shopping, all of that.
All the things we take for granted in life.
Yes.
Yeah. Peter?
So Alzheimer's patients are amongst the most vulnerable in our healthcare system. They ping pong around in the system. They often get fragmented care because providers, doctors and surgeons and other providers don't know which medications they're on or what their diagnosis is. They may get admitted to a hospital and for pneumonia or something, and the doctors there don't know that they have the dementia. It's really important for people going through this to have a plan to centralize their care, to make sure they have a good primary care doctor who's on top of it, and that they really think through the goals of care as they go through this process, which is very difficult, but
And have an advocate, an advocate, like if you,
a healthcare program.
it's so important if you have dementia and you're going into the hospital to have a family member that's paying attention to everything that's happening. And
Healthcare proxy, power
so
of attorney.
healthcare proxy is important for everybody, but especially people with those signs of dementia. And the power of attorney, yes. So that's another good reason why we want people to be investigated. We want them to have sense of what's happening for their future, so they can plan around
Now, this
that.
is potentially one of the largest groups to be exploited by nefarious characters out there, both in the family and outside of the family.
That's right.
What services are and what watchdogs are available
So
to you?
there's
in that?
protective services for people over 60 all throughout the state who, for physical abuse, neglect, financial exploitation, sexual abuse. I think that's it. Those are the main categories. And there are mandated reporters, which social workers, nurses, doctors, police officers.
Fire.
They're all mandated reporters, so when we suspect either neglect or abuse, we make a report. Again, in our area, it's Minuteman, Senior Services. Protective service worker they'll take the report, and if it's screened in, if there's enough evidence, they'll investigate. And their goal will be to obviously alleviate whatever's happening, whether it's neglect or abuse, but also to try to help the person, again, the least restrictive method in terms of trying to keep them in the community if it's still safe.
What is your experience with how responsive? This is a state-run organization, I presume, Protective Services.
Yes.
How responsive are they in your experience in terms of answering these questions?
They're excellent.
Yeah.
They really are.
That's
I
been
mean,
my
they're
experience, too.
understaffed, I'm sure, and underfunded, but they do a really good job.
What is interesting is the National Institute of Aging kind of estimates there are about 5 million patients in the United States. And so naturally you need more services. And biologically you have the caregivers also go through the stress response. And so that stress affects the caregiver a lot than what we understand. But that's why there's a lot of research on caregiver also, about how the stress actually activates their own systems. And they are also vulnerable to disorders, diseases, unrelated to Alzheimer's, but they also need to be taken care of. So you have kind of combination at the same time, while the Alzheimer's patient, because we know in the brain the different regions of the brain are connected together, so they go through this progression affecting different regions, additional faculties. So they not only lose memory, they then become progressively incapacitated and could become violent. So the caregiver gets more and more stress as the patient progresses. So that's kind of it's kind of an unfortunate thing, but that's the way it is right now. So that's why the caregiver system has to be much more robust.
Okay, we've only got a couple of minutes left, so what I'd like to do is kind of go around the table and have you make closing arguments in your area of expertise, how to reach out to you, what your optimism is for the future. And we'll start with Peter and then go to Omanon, and we'll close out with Brenda.
There are many very promising research studies currently going on directed at treating Alzheimer's disease. Whether they are going to help us depends upon whether the amyloid hypothesis is true. And I think we're going to get an answer to that question in the next several years. If it's true, then we will have figured out a way to prevent Alzheimer's disease. And those of us sitting here and of our age group will be more or less off the hook. If not, then if the amyloid hypothesis is not proven to be true, then we are looking at a long slog of research. As Omanon mentioned, there are inflammatory hypotheses, vascular hypotheses, sleep deprivation hypotheses, and many, many, many other biochemical processes that are being investigated as upstream causes of amyloid pathology in the brain. So we all have our fingers crossed that these anti-amyloid strategies will work. We'll see.
How can people reach out to you in the veteran community in reaching out to you to receive services in your area of expertise?
Any veteran who's concerned about their memory or about incipient Alzheimer's disease should have a low threshold to contact their primary care doctor. There are VA CBOCs scattered throughout New England and across the country. The New England system in particular is very integrated, and the primary care doctors at any CBOC, any clinic, can connect you to specialists at the hospitals in Bedford and Boston. Like as I said before, the VA has resources to provide care for veterans from the earliest stages in the diagnostic stage all the way through, and they have a great support system. I strongly recommend that veterans out there take advantage of it.
Omanan, your level of optimism and to address whether or not you think we're spending enough money to find the answers.
Well, the answer is we're not spending enough money on the problem. But at the same time, the research is being done in mice, it's being done in flies, it's done in worms. And unfortunately, we are not either of any of those. And as Peter pointed out earlier, is unless we really recognize and define and describe what actually happens in the humans, we can't really get a solution to it. And again, it goes back to the amyloid hypothesis versus the other hypotheses. And people are trying to figure out which ones pan out, and that's where the hope is, that long-term research, find out the right answers, and then design appropriate medications based on that research. And that's where the hope is. And may not be today, but long term, yes, there is a lot of hope involved in it.
Brenda, your level of optimism, are we collectively taking care of these people as a society?
Well, I think we can always do better. We're trying. There's a lot of great people in the field that are working with seniors and younger people too. So I would say, yes, you should have hope. You should always have hope. I would also say, if you are worried about yourself or you're worried about somebody else, reach out to the Alzheimer's Association, reach out to your local Council on Aging Senior Center. All have outreach workers that can help you to get connected if you need help connecting up with services or even medical care. So don't worry alone and reach out.
Wonderful. Okay, unfortunately, we've run out of time. I'd like to thank our guests, Dr. Peter Moran, Dr. Omanan Cole, and Brenda Pappas of our own Burlington Council on Aging. Our program has been Alzheimer's Demystified. Thank you for joining us. Thank you.
Thank you.
Thank you.
Thank you.
Stay tuned for our interesting interview relating to Alzheimer's.
Kirk, thanks for joining us. Your mother, Marcia, suffered a rapid decline due to Alzheimer's disease and then succumbed to colon cancer. During her Alzheimer's phase, she had a common symptom known as agnosia. She never realized that she had memory loss. How did that blind spot complicate your sense of her illness?
It was really a blessing in disguise because of her strong personality, and to admit that maybe something might be wrong with her would have been very difficult for her or for any of her friends to know it. And so that blind spot turned out to be a gift, I believe, more than anything else. We were able to work with that. It would have been very difficult, I think, had she known more about her illness, because she would have learned more about it. And that isn't always such a good thing to do.
Right. What was the greatest challenge of managing her rapid decline?
The greatest challenge in managing her rapid decline was finding more than just my wife and myself to care for her. We realized that she would need somebody, and she'd had fallen about a year before on some ice outside, went outside to adjust a Christmas light that wasn't just so. And I asked for a former employee to come give me a hand. She was studying nursing. And I called upon her to help me again. And next, we slowly ended up assembling a team through word of mouth. And we had 3 or 4 people to start with, tending to her, generally towards bedtime, and getting her up in the morning, getting her fed, and then probably getting her settled down at night and making sure she had dinner. That was challenging. And then needs changed, and we needed more people. And I can't take credit for that. I give it to the first few girls that really started out, and the one that my brother appointed as the chairman of the board on one of his trips home.
So you were really lucky to get a great group of people that were willing to work with her and organized, because you weren't in the area, is that right?
I lived just about a few blocks away from my mom. And being in business in a small town, you tend to know a lot of people. And my dad owned the business before me, and she was fairly well known. And that in itself made it a little easier to have people step up and have an idea what they might be getting into. And I would say the references that the fact that a lot of people knew who she was made it a little bit easier. And some of the girls that cared for her to start with were able to find other people that maybe needed some additional money, a part-time job. And it slowly grew. It was amazing. I don't have a good answer other than it just kind of came together. It was a challenge, but it kept together. And the women, one woman told me one day, Kirk, I thought I was here to help your mother, but in fact, the result of this was she ended up helping me.
That's wonderful. People often find that when they're helping someone, they really, it brings out the best in everybody. What were some of the ways they all communicated with each other to keep everyone on the same page?
One of the girls did something really unique, and maybe not everybody would approve of this, maybe people that are paid by an agency, but one of the girls set up a Facebook site. It was a closed site. You had to ask to be a member of it. Each and every day they would report what they'd done that day, whether they'd been out shopping, looking in antique stores, feeding the ducks at the park, all the exercise that they did to keep her active. Played Scrabble. She loved to play Scrabble. She didn't spell the words always right, maybe more like a young person would do, the way they sounded, not the way they're supposed to be spelled. But they could convey that when they left. The next person coming in or the shift after that would know what to expect and what had happened that day. And the brother in Los Angeles always knew what was going on. What a benefit to family members to know what's happening if they don't live in the area.
That's very important, as you said. And the caregivers, they're special people.
They are.
They know, they're creative, and they know how to keep her busy. So that sounded like you had a great group.
You develop, they learn more about her the time they spent with her. But each time I had a new caregiver, each time I brought along a new caregiver, I'd say, go ask her how she planned to build this house, when she built this house, what the plans were like. Each time we had a new caregiver, I'd say, if you need to divert her a little bit or want to warm up to her, ask her how she built the house. And that was a long story. She'd tour the house with them. It was a great way to start off with a new relationship.
So the older memories were still present for her. She was able to access that information.
She lived in the moment most of the time, but yeah, she had great access to her past at times. She's not one that lived in the past, but there were some memories of the past that she would bring up. She forgot about her second marriage for a while. And a lot of people forgot about it. Actually, it was fairly short. But yeah, you never knew what she's going to remember. You just didn't know what was going to come up. If you told her a story that day to divert her to something else, you might get caught. So you got to be careful.
You told another story about a caregiver who tried to get in one day and couldn't. And so what did she do?
One day my mother met the caregiver at the door and sent her home. Said, I don't need your help today. The girl immediately walked out of the garage, which is where we enter our home, stood in the yard for a minute, came back to another door, knocked on the door, and said, hi, Marcia, I'm here to watch television with you and maybe have some popcorn. Well, come on in.
A different approach worked.
A whole different approach. It's like starting all over.
You mentioned that she fell down and that got your attention. Was that the first sign that there was something wrong?
She did fall down about a year before she ended up having full-time care, but no, the first signs were more like a little confusion getting home in her car, taking the long way around town. She actually got lost one day in a neighboring town. Getting her hair cut every Thursday was very important in another town. Had to go to another town and get her hair cut every Thursday. And she got lost one day and called me on her cell phone. She knew my number. So she got lost one day in another town. And that was probably one of the first real key things that happened.
How did you feel when that happened?
She didn't forget that she got lost. She remembers that very well. But what she remembered better was when she had to go for a driver's test, because I requested the state do that she passed the test. Well, he told her everywhere to go and what to do, as opposed to not knowing how to get back to the driver's station by herself.
How did you feel when your mother called to say that she was lost or had gotten lost?
Ironically, I thought it was an important moment because it was one of those signs where she realized she couldn't be as independent as she'd been for many years, living alone after my father died many years before. So it was a good thing for her to remember.
Mm-hmm.
When her dementia became advanced, she developed mysterious complaints of somatic pain in her scalp and her hands. And all of that only resolved after her cancer surgery.
We wondered a lot about that, the displaced pain, the scalp, the knee, the leg. I don't know where that came from, and I still didn't have an answer for that, but can you ask me the question again?
Well, you had to make some difficult decisions
Yes.
About pain management and about cancer treatment.
Okay.
What was the goal of her care at this more advanced stage when she was going through all of that?
You know, on New Year's Day, we'd taken her to an emergency room visit again. My mother made several visits to Florida to a doctor for a sore throat, and we found when we went to visit her that there were all kinds of vitamins and medication around. And I got rid of most of that and brought her home. When she was home that year, while at home and complaining about pain, we took her to the ER a couple times, but on one such occasion, we discovered she was full of bile. And in fact, the doctor concluded she had colon cancer, where in fact the doctor concluded that she had cancer and a blockage and would have to have a CAT scan. And after visiting with the doctor and her diagnosis of colon cancer, it would require surgery. We certainly jumped upon that opportunity to take care of the surgery. She recovered very well, but the day we went for the follow-up meeting, when we left the yard, she couldn't remember she'd been to a meeting with the doctor. From leaving the office to leaving the yard of the hospital, before we left the yard of the hospital.
So she forgot that she had cancer.
She totally forgot she had cancer. She had no idea she had cancer. And based on the way that my mother, she'd forget about anything after about 10 minutes, and sometimes less than that. Treating her with cancer was a decision we made. How we treated her with cancer had a lot to do with her personality, and appearance was a very important thing to her. And so we decided not to pursue cancer treatments. The cancer was fairly well advanced, so we therefore got 24-hour care and provided for her all we could. And instead of telling her why her hair would fall out or reminding her every day we'd have to go for a treatment why she was going, because she simply would not remember. She'd forget when we were going to a friend's funeral from the time we left the house to the 5 minutes later arriving at the church while we were going to the church. She lived in a moment, and those moments were wonderful moments. But to have reoccurring negative news would be a detrimental thing to her
And
life.
you and the rest of your family knew her the best. And so you knew ahead of time what her wishes were as well, in terms of what she would want or not want.
Yeah, life-ending event. You know, my father had ALS, and he had care in home, and she also said, you know, I'm going to die in this house. I'm going to die in this house. And she didn't know she was going to die, but she on several occasions would say, if I get sick, this is the place I want to be. I don't want to die in a nursing home. I want to die in my home. And she made that very clear to not only myself, but
So that helped you to make your decisions going forward.
it did. And I think that's becoming more and more common today for in-home care. It was a great experience for us.
Let's talk a little bit about pain management.
Okay.
Did your mother have a lot of pain when she was suffering with the cancer?
The most pain my mother experienced seemed to occur right after her operation in the ICU. And although she appeared rather well, she complained constantly of pain. And what we found to happen was that the nurses were treated, what we found to happen was that the nurses were trained to treat the patient. The nurses would treat the patient with pain medication as they required it, or as they demanded it. And when looking at what had been dispensed in a day, I'm like, oh my goodness, she's not a very big woman. This is a lot of pain meds. So we brought in Tic Tacs, and I'd used those before. And the hospital didn't like it much, but I gave her a Tic Tac when she wanted a pain pill. And that would seem to subside the pain. On other occasions, caregivers in the house would say, well, I gave you one of those a few minutes ago. She said, that's right, I'm a little tired today, I must have forgot. And they would believe, she would believe her care providers. And the Tic Tacs became a magic pill for pain as time went along.
Which was a lot better than pain medication.
Yes.
If symptoms can be managed that way, that's
Yeah, and many times,
to her
in many
benefit,
cases, it wasn't
sure.
pain at all. It was just a feeling she couldn't quite explain. And you know, you cannot reason with a person with Alzheimer's. It's very difficult to reason with them. Or challenge them. It's a terrible thing to do. You go along with them and you divert. But I would forget on occasion, I'd try to reason with her why she couldn't drive a car. It never resulted in something positive. It's better off to avoid the subject as much as possible. Nothing good came from it.
Your mother passed away about 2 years ago, so you've had some time to reflect. Is there anything that you wished you had done for her, or that you wished you had done differently during the period when you were primarily responsible for her?
Not really. What I'd really wish I could do is share our story with more people that are going through the same thing.
Yeah.
There are things that providers can't share in a, whether it be the area, there are things I wish I could have provided other people with. Areas of an agency, I can't say that. Let's see, how am I going to answer that again?
Council on Aging?
Yeah. I think we did a really good job, had a lot of support, and I'm very happy with what we did for my mom, but I wish we could share some of our experience with other people.
You wish you would have had a support group at the time, perhaps?
No,
or
I think we had a great support group. The Women Helping were my support
Okay.
group. But
could you have used more connections with other people going through the same sort of thing?
no, I don't believe so. I think we'd had enough experience. How can you not sound pompous?
What did you want to do? You wanted to share what was working?
Yeah, I felt that what was working for us, I'd like to have shared that with other people, because it was working so well. And there are many people with a strong personality like my mom from that generation that will never be told, tell a story to them, give her a Tic Tac when she's had her meds so she thinks she's having a med again, instead of telling them, well, no, you've already had it, and having an argument about it when they can't remember. There are many little secrets that we discovered that would be fun to share with other people.
Right. The caregivers really knew how to get done what they need to get done without getting sidetracked.
Yes. And I met other people on occasion out walking their wives, or I'd go to the nursing home to visit a friend and go in the PEC unit and visit with people in there, which is a unit for people with Alzheimer's. And there's so many different walks of life that these people come from, and they're affected in so many different ways. There's no one real answer, but you'll find your own somehow with enough people around you.
The important thing is to have the support around you.
Yes, my wife was a tremendous amount of support to me, and the friends, what we call Team Marcia, were tremendous. That make me cry right now if I think about it.
Team Marcia.
Marsha. Yeah.
There it comes.
Yeah.
Yeah, they're good people.
Does the team still hang together, or they're connected through Facebook?
Yeah, wait till I dry my eyes here.
Did you keep the Facebook page going, or?
Yeah.
Yeah.
Yeah. Hold on a minute.
Okay.
Help, Louise. I'm good. So, Team Marcia, yeah, we kept our Facebook active. I post something on there the other day, Mother's Day. One of the girls put a picture up of her mom and my mom together.
Nice.
Beautiful.
Nice.
Yeah, beautiful.
Nice way for you to be able to remember her through these other people as well.
She, stop talking so they can't film me while I'm crying. She loved to dance. And several of the people that helped her would take her out dancing.
Take her out.
And she'd dance with one of their spouses. And exercise was really important. Exercise, playing Scrabble. She wouldn't spell the words right, but boy, she spelled something.
The activity itself.
Yes. And winning was important.
Yes.
So Team Marsh was a wonderful group of people. Whew. Hey, we got there, didn't we?
I guess so.
Yeah. One of the key things we did was taking away the mail from her. That's one of the first things you're going to see with a patient when they start having problems, or with a person. One of the first things you're going to see is mail strewed all over the house or all over the table, and they can't organize things anymore.
Right.
And my suggestion is to divert the mail to another address to a family member. The bills will get paid. The junk mail, just segregating the junk mail is so important because she thought she needed car insurance. And she didn't. She's on a dealer plate. She didn't need car insurance.
Potential for fraud is there, and also there are money management programs that can help people as well.
I was unaware of that because we have a friend who just seen their parent go through several $100,000 in another state. They just took all the money she had. She second mortgaged her house. How a banker was able to. I shouldn't have put it that way. People do some crazy things. And can be preyed upon very easily. Take away the mail. One day my mother got a phone call from a telemarketer, and one of the helpers was listening. And her answer was, well, I guess if you are my bank, you know what account number I have, and you wouldn't be asking these questions.
She's a tough cookie.
She was tough.
So you've touched on all three of the main categories of safety risks. Machines, her car.
Yes.
Medications in Florida, a mess.
Right.
And crooks.
That's right.
Scams.
Get the mail away from them.
Right.
And I don't know how you can do that legally, but get the mail away from them and set things up ahead of time so you can pay bills. You need to make sure that that's taken care of.
Yep.
That's
A lot
crucial.
of,
That is probably the greatest challenge that I really didn't think of when we were talking initially. Probably one of the greatest challenges is making sure bills get paid and having provisions to do that.
Yep.
It might be the best thing to change the address of all the bills that come in to the person that's going to pay those bills.
Like you said, it's one of the first signs when someone's struggling, they cannot keep up with making sure their bills are paid.
You can't live without heat and water, and somebody needs to be taking care of those items, and taking that away can be sometimes difficult. Maybe you got to be crafty. I don't know how you're going to do it, but make sure you have plans in place to do those things.
It comes down to that, especially with a strong character like your mother was.
Yes.
Is you meet resistance. What do you mean you're going to take my car? What do you mean I can't pay my own bills? So sooner or later, unfortunately, very often later, somebody has to step in and say, we're doing it this way.
You might have to start by doing it with her. You might have to start by sitting down with her to get the bills paid.
I had an occasion one night where my mom was convinced that there was people in the front yard. They were carolers, Christmas decorations. And she called the police, and they called me and said, Kirk, your mom thinks there's people out in the bushes and they're the decorations. And so I went over to see her. Several nights later, she was seeing things, and there were people dancing. It was, in fact, trees blowing in the wind. But she'd been taken off a medication improperly by her primary care physician. And it was one of the memory medications that Dr. Morin had prescribed. The coordination of medication with the patient is very important, and sometimes the PCP has no clue. Maybe that's where the pharmacist comes in. On this one occasion, I called the police one night as she was hallucinating, because I knew Joey was on, my friend, and he came up and she started on him about, do you think it's fair that I'm living alone and I can't drive a car? He says, well, you must be about 78, aren't you? Well, yes. Well, that's that new law they come out with. He said, you can't drive after you're 78. And so, I mean, from the support.
Did she accept that?
She accepted it from anybody but me. Yes, from anybody but me, she'll accept things. Interesting, but that important point was the medication, Dr. Moore, you probably don't run into this very often, but she was on something besides the Namenda. I'm not sure what it was. She came down off too fast. Her PCP took her off it for some reason. And it might have been an anxiety medication, but the process of coming off it too slow caused hallucinations. And coordination of medicine and the importance of a good
Communication between
what's
the
the word I'm looking
doctors.
for? Doug is a pharmacist. A great pharmacist is a key ingredient to this, and being aware of the patient, because medications can be prescribed different from what the neurologist might prescribe that could be conflicting. Somebody has to monitor that stuff.
Do you want to ask any other questions that might interface with the Alzheimer's Association or the process of garnering support structure? I mean, Kirk's situation was in some ways atypical. He had resources. The
Yeah.
more typical case that shows up at the Eastern Agency on Aging is somebody who shows up with no resources and says, "Help me."
Let me give you a quick story and I'll get out of it. We had a 91-year-old man used to visit the dealership every day where I work. He was a great friend of my father's. We thought he had Alzheimer's. We were convinced that he did. What we didn't know is his wife did. And he was being offended by her, beat on by her. And there was no family in the area. A niece would come up as often as she could and try to look after him. What do you do when you have two adults in their 80s and 90s and need help?
That's where the Council on Aging will come in, the agency in the area that handles protective services, people that really need support that don't have the family around. In our area, it's Minuteman Senior Services.
Yeah, we see it a
So
lot.
a report to a Council on Aging outreach worker or to Minuteman Senior Services is the right thing to do. In that
The last
case.
thing we wanted to do is call, a government agency and say, this man's being abused. We didn't want to
So
do
what,
that.
what
but
the agency would do is they would help the person to remain in the community as long as it was safe, and that would be their goal, the same as the Council on Aging. Our goals would be to help the individual, the family, to address the care needs and try to keep the person in their home, which is usually what their first choice is.
Did you find any internet-based information sources useful, such as the Alzheimer's Association website?
My wife did. My wife used the internet often and found some common characteristics. She was a research portion of this. Regardless of how large or small a family you have, you all become involved in some fashion or another. And I think communicating via the internet is often a better way to do it, because you write down things, you don't say things you wish you could take back. You write things down and you put them in letter form, and there's a lot to be learned from the right sources, like the Alzheimer's Association.
So did Marcia have any trouble with particular appliances or machines that she had to use around the house?
Oh yes, the thermostat and the microwave. The thermostat was difficult to understand. It was either on or off, and when it was on, it was all the way turned up, and off was all the way down. There was no in between.
We're talking about northern Maine here.
We are, but I ended up taking a penny and taping it in there so she could only turn it up so high until she found that. The microwave was used often because I would buy pre-prepared meals for her before we had in-home care. I'd go to the grocery store, find some pre-prepared meals. She never really forgot how to use a microwave. I don't know why, but she didn't. And she unplugged it every time she was done using it because it saved money on electricity.
That was safe.
Yes.
How about the stove? Did you find her?
No, she was scared of the stove. Believe it or not, she never lost common sense, which is unusual, but she lost her memory. That 10 minutes, or 5 minutes, whatever it might be, or 2 minutes, but she had some experiences that were probably negative enough that she never forgot them. Which
That was
I think
one
is-
battle you didn't have to fight with
Yeah.
turning off the stove.
With the car, go and hook the battery. If they want to have a car in a garage, and instead of having keys made, like a friend of mine's mother had over and over again, keys made for the car because they took the keys, unhook the battery.
What about the bathtub?
The bathtub, that was a difficult one. It overran several times. She'd forget she turned it on. And then she began not to bathe. And that's a very common characteristic I'm finding with people with Alzheimer's and their cleanliness. Does my hair stink? And she'd, stick it in front and say, now, Mom, you haven't had a bath or shower for 3 days. Again, a very proud person. The help that came in was able to handle that battle. As a son, I couldn't go there.
Yeah.
It was difficult.
Yeah.
And taste and smell. She'd drink sour milk.
Mm-hmm.
And I'd say, Mom, that milk is sour. You drink it. And she'd show me how she could drink some. And in the spoiled food, so we would, oftentimes when she had her hair done, she was out with somebody, we'd go clean out the house. All the old food, all the old meds, whatever we could find. And one interesting thing, she had a red mock turtleneck she wore most of her life. And that was in June. It was when she went out, she looked great in red and great in aqua. So we found her wearing this mock turtleneck a lot. So we bought 2 or 3 more just like it. They'd gotten so pilly. And ironically, when we cleaned out her house after she passed away, we found a picture when I was like in 7th or 8th grade. She was wearing the same mock turtleneck.
That was a favorite, so you were smart to buy a few.
Yeah, Louisa's idea, my wife's idea. Let's buy some more just like it. Let her wear a red mock turtleneck every day if she wants.
That's right.
That's right.
Keep them happy.
That was perfect.
Don't argue with them. It doesn't work.
Right.
Keep them happy as you can. If they like a shirt that they're wearing, get another shirt just like it.
What you said about the bathing, it's a very, very complex task to take a bath. There's, I think, something like 18 different steps involved. So it's no wonder, really, that that's one of the other areas that people start to have trouble with.
She loved her tub. She could lay in a tub for a long time. Getting in and out became complicated. And being proud, what the ladies would do is hold a towel up so she could get in and out of the tub. We had a shower unit my father used to use. She didn't care for that. She liked her bathtub. That's where she was comfortable. She began to hide things also. Very common. People hide things. She never accused anybody of stealing anything, but she had a lot of very valuable jewelry. And she was smart enough to tuck it in a bucket and put it underneath her sink in one of her rooms and leave her costume jewelry laid out. But we tried to eliminate as much confusion by moving things away from the bathroom as best we could. But getting in and out of the tub, just give them as much dignity as you can. But and going to the bathroom, even sometimes talking through the door would work, because it could take a long time sometimes.
Right.
Anything about the tub I could cover? I don't know how you get into bathe more often. The hairdo, getting their hair done was an important thing for the older generation, or getting a hair cut. It's oftentimes easier to say, Marcia, don't forget you had an appointment on Tuesday, when she didn't have one. But you tell them that they had an appointment. And one thing I didn't mention also, we put a whiteboard in the kitchen. Every day we put the day and the date on the whiteboard. And we'd list who had called that day or who had visited. Because she would say, none of my friends are calling me, nobody comes to visit. But in fact, if you documented it each day on the whiteboard, or even a few days, and another thing, holidays, celebrate every one of them. They love cards. They love balloons. She read her cards over and over again from her friends. She'd say, I have such good friends.
Yes.
Oh, and this one's from you. And would read cards over and over again. And finally, shopping, the grocery store became a problem. My daughter worked there. And she'd come in and roam around for 45 minutes, and then she'd buy wine. Then she'd go to another store and buy wine. And then she'd get home and have a bottle of wine and forget she'd had a glass. Well, I didn't have any wine yet, pour another glass. Didn't have any wine yet, pour another glass. But the shopping in the grocery store was a very difficult task, and people noticed it and they'd contact me.
It becomes very overwhelming and confusing.
It's like the menu at the
It's just too many things.
Yeah, it's like the menu at the restaurant. You know, Mike, you know what I like, because you can't read it, you can't comprehend it. And the news was always the same. Because the set was the same, she thought it was the same news being repeated. All the TV shows are repeats. So you divert her to the traffic outside, which was always different. Any diversion you could think of.
She was a very challenging
It was
character.
fun.
She's a very strong character with expertise in healthcare.
Yes.
One of the more challenging Alzheimer's patients that I've encountered in terms of the strength of her personality. You guys did a magnificent job in setting up a system to direct her and keep her safe while preserving her dignity. It was really impressive.
Probably the most gratifying thing I've ever done, besides having children and being married.
I can understand your impulse to share it with other people. It's good.
Yeah,
I hope this helps.
the support that I had was just amazing. We forget about how helpful our spouses are, and even my children, as young as they were very, very helpful.
Wonderful opportunity for them to see what you're all doing.
What lies ahead of us in life, yes.
Exactly.
And the one thing I fear is our generation will not be that strong. I fear that we'll see a lot more suicides. A friend of mine's father did it not long ago. I guess I wouldn't want that on camera. But I'm afraid we're going to see a lot more. We protected our children so much. I'm afraid this next generation is going to attack this in a different fashion.
Well,
And I hope there's more care for it.
we're already seeing less strength in the bonds that hold people together as they go through this process.
As the greatest generation
Yeah.
Yes,
starts to,
that's sad.
It used to be that the spouses were together all the way through to the bitter end, every
Yes.
meal, every minute of every day.
I've seen it.
Now, as soon as they get to a certain point, people bail.
Yeah.
It's amazing. This has just happened in the past 10 years. It's going fast.
We're
Where it goes, it's a little disturbing.
Yeah, we'll just hope and pray and keep researching for something that'll help us determine what seems to be causing this crazy disease.
Thanks so much.
Yeah, I really enjoyed it a lot.
Thanks for
thank you
joining
very
us.
much, Kirk.
Thanks.